Hi, my name is Asha Devereaux, and welcome to a presentation on COVID-19 and the self-care kit that I've given you. I'm sorry you missed the presentation on May 30th that we did live via Zoom, but I hope this presentation catches you up. To the right is the kit that I hope you all have received, and to the left is a picture of me in the early days of testing, showing me wearing a motorcycle face shield that I got off of Amazon.com and with an N95 underneath. And I was doing COVID testing for an individual. The shortages in PPE are very real. And at this time, all of it was reserved for hospitals. And so that's why I was being creative. And I think we still are being innovative and creative in terms of PPE and personal protection. So many of you have asked, what have I been up to in the last couple of months? And I just wanted to share with you some of the work that we had done, back in 2007, uh, about critical care and preparation for disasters. And then it led to another publication in 2014, care of the critically ill and injured during pandemics and disasters, and a whole multitude of activities that you really don't talk about on a day-to-day basis during patient care. However, during this COVID-19 pandemic, triage, surge, allocation of scarce resources have become common terminology. And I just wanted to share with you some of the work that we've been rapidly developing over the last couple of months with a slew of other people across the world as well as across the nation, and including some collaborative work that's just been published. I think this response, when we were publishing, was based on federal guidance and had assumed significant federal oversight. And in this publication, 50 states or 50 countries, what did we miss and what do we do now? Dr. Skip Burkle, one of the leaders of triage, and I put together some thoughts on how we can make the WHO, CDC more resilient, get them engaged back into the business of public health. I know there were lapses in judgment and mistakes made, but we do need a centralized and strong leadership to get through this so that there aren't any conflicting messages. The County of San Diego asked me to help with translate some of our work from the previous documents and see what we could do here in San Diego so that we can bring our community together and share scarce resources. So over the last 3 months, I've been involved in this area where we have the green circles in developing community consensus around some difficult decisions, and there's still much work to be done. But I just wanted to update you on what we've been doing here as well. So many of you will recall in February when I initially gave our flu talk and we discussed this coronavirus. At the time it was called Wuhan coronavirus and 2019 nCoV, and now it is called COVID-19, which is coronavirus-induced disease, and 2019 is when it was started. The coronavirus is named coronavirus due to this glycoprotein external helix around the virus, and it looks like a crown. There are 4 major categories of coronavirus. They are common throughout the world, but only 7 different coronaviruses infect people, and it usually causes a mild to moderate disease, and it's considered to be 30% of common colds. The beta coronaviruses are the ones that are more pathogenic to humans and much more deadly. Of the 4 categories of coronavirus, alpha and beta impact humans. And it's the beta ones that have mutated and have resulted in diseases such as the first SARS that we saw in Toronto, where they had 8,000 cases and 800 deaths, and MERS-CoV, which has a significant transmission and can and is also causes significant death. These had mutated and shifted from an animal reservoir from the dromedary camel for MERS and the civet cat for SARS. Our novel coronavirus now is a distinct clade, but it shares 79% genetic sequencing, or nearly 80%, with the SARS-CoV-1 from Toronto. So that's why it's called SARS-CoV-2. And it's felt to have come from a bat reservoir because it has a 96% homology to a bat coronavirus. There's still a lot unknown about how this virus entered the human population, and more studies are pending. As we had mentioned in our flu talk in February, there are different phases of pandemic response. The WHO has certain phases, and the US response has a certain category of phases. I think we can all agree that we are currently in stage 5 of the US response to the pandemic period. With the way communities are opening up right now, many feel or get the impression that we're in the recovery phase. But I'd like to point out that our hospitals and intensive care units are still facing significant shortages of masks as well as cleaning supplies. And so the recovery will be mixed and likely prolonged. So when I originally gave this presentation in March, these were the red circles of coronavirus, the SARS-CoV-2, that was present in the world. 60 million people at that time were under a lockdown, and there were about 90,000 cases confirmed. Outside of China, there were about 7,200 confirmed and in 58 countries. And at the time in the US, there were only 103 cases with 6 deaths. Mandatory quarantine was in place and a travel ban had been imposed, and they were just kind of giving warnings about reconsideration of travel to South Korea, Iran, and northern Italy. Now, there's globally, within just the span of 2.5 months, nearly 6 million confirmed cases and nearly 500,000 deaths globally, with the US leading the way, unfortunately. In San Diego, we started lockdown relatively early, and our caseloads are only 7,200, maybe a little bit more this week. Our hospitalizations have been fairly low, but we still do have some mortality. I'm proud to say only about 3.7% of our cases have died. So our mortality rate is much better than the nation's. And likely because of the lockdown and the slowdown, we have time to create plans and prepare and communicate and develop protocols which benefit our patients. So currently, at the time that I gave this presentation on May 30th, we had 140 new cases in San Diego. There were 6 deaths that day, bringing our total to 266. The age range that week between 44 to 94 years old, and all but one had an underlying medical condition. So it's important to note that people can be relatively healthy without any medical conditions and still be affected by this virus. I think one of the things that gave us a false sense of security was in February this article was published. It's one of the first in JAMA that stated the age distribution. This was by the Chinese CDC. And it said this was a disease that predominantly affected adults and with a case fatality rate that was overall 2.3%, and mostly affected people over the age of 80. What was concerning to me is that the critically ill, there was a 49% mortality, which as an ICU doc is concerning. And they were saying, well, it affects mostly people over 30 and maybe over 50 and maybe tobacco related. And I think that gave the world, and at least definitely gave the United States, a false sense of security. And maybe that this information hindered some planning. If we look at some of the early epidemiology, they felt that this virus was predominant or prevalent in the Huanan seafood market. Since of the first 100 patients, 50% of them, nearly 50%, had an exposure at that market. They had done some nasal swabs and they said 51% had underlying chronic disease. The average age was 55, but as I look in the mirror, it's my age, and it's pretty relevant to all of us and concerning that all of us could be impacted. The chronic diseases that they said people had was high blood pressure and diabetes, which afflicts nearly 60% of our population. And the symptoms were very flu-like. Fever, cough, shortness of breath, muscle aches, sore throat, runny nose did happen, nausea, vomiting, diarrhea. But since that time, we've learned a lot more. One of the important things we've learned is how this virus enters our airway and attaches to our respiratory cells. In our airway epithelium, we have cells called the ACE2 receptors, and the glycoprotein that I had shown you before attaches to these ACE2 receptors, and it helps bring in the virus. The SARS-CoV enters the cell, and it uses our engine to replicate and then regrow and develop and buds out new virus particles. And there is some theories that this ACE2 receptor can actually be suppressed or blocked by some of our common blood pressure medicines, which we call ACE inhibitors, and angiotensin receptor blockers. In the early days of this disease, there was thought that maybe people with high blood pressure on those medicines actually had something called upregulation, so that they had actually more of these receptors present that permitted the virus to then multiply a little bit more aggressively in those folks. Now there's some studies that are starting to take place that says, well, maybe those high blood pressure medicines may be protective. So this is new thought, and we are still waiting for those studies to be released. In the New England Journal last week, there was some publications about the timeline from onset of disease or onset of exposure. And now that we've got some time and we're able to monitor folks, we know that the virus can hibernate in people. There's something called the asymptomatic transmission, which we'll talk about. But also that this is where the virus is genius. It can harbor in us about 5 to 7 days easily, if not longer, before causing us to have a fever, cough, fatigue, shortness of breath, lack of appetite. You can present with a lack of smell or taste, or even just have pink eye, and you could have COVID. There could be a rash called livedo reticularis. There's something called COVID toes. We've seen something called hypercoagulability, where people will have blood clots, kidney failure. In the critically ill, about 40% of symptomatic patients will have shortness of breath, and then 14% will go on to have a severe illness, and then 5% will end up in the ICU. Here are some images from that article showing what the x-rays and CAT scans and what COVID will look like. This is on panel A, an x-ray of an individual in the ICU on a ventilator because there's this tube in the airway showing these whitish, hazy opacities throughout the lungs. A cross-sectional view by CAT scan shows these cotton ball-like lesions, which we call ground glass opacities. The good news about ground glass changes is that those are more inflammatory and thought to be reversible. In lung ultrasound, that's a novel way to image the lungs. There's a characteristic finding of these rays called B lines. And here is how the virus causes lesions in the brain. So when I was trying to look up some studies that are currently in progress in San Diego, compared to what was listed in a New England Journal article, of note is something called remdesivir, which I know it's been in the media recently. And the study was done at UCSD and Scripps. And there are still some ongoing remdesivir protocols in place. I know that Gilead, the maker of remdesivir, has released the drug on a volunteer basis and donated multiple doses. However, it's just not enough for all of the people hospitalized, so it is considered a scarce resource. Chloroquine data recently has shown that there's an increase in mortality with higher doses, and that it's really not effective in prevention. And if you do have COVID-19, because of the cardiomyopathy that results in this disease process, hydroxychloroquine may actually be harmful for the heart. There are some studies on antivirals, remdesivir, which I'll show you more slides about. And there's a look at lopinavir and ritonavir, which has been used in HIV infection, and hoping that may slow replication. There's also some promising data from convalescent plasma, and that study is ongoing here at Sharp Coronado. They're also looking at Pepsid and hyperbaric oxygen. Those studies haven't started yet in San Diego. Stem cells and colchicine are being studied at UC San Francisco. And sarilumab, which is an immune inhibitor, is studied at UC Davis. So everybody's trying to help mitigate this cytokine storm, which is this inflammatory reaction that can happen due to COVID, or try to stop the virus from growing in our systems. So let's look at remdesivir, which has been in the media quite a bit in the last week and a half. And basically, it is an antiviral that, if you think about the flu medicine Tamiflu, it's more beneficial if you administer it in a certain earlier window of illness than after your body has already started its chain reaction of inflammation and symptoms. So you want to try to catch the patient a little bit early. Here are some Kaplan-Meier recovery curves that were published that shows that remdesivir compared with placebo provides a better response and shortens the days of the illness. In patients who are not receiving oxygen or just on oxygen, the curve widens and there's actually a better response. However, if a person's already getting mechanical ventilation, that means that they are more severely ill or impacted. There's really no difference. And those who are on ECMO, which is probably the most significant intervention we can offer for our most severely ill, there's actually no difference between not getting remdesivir. So the best thing is try to catch folks where they are most likely to benefit. The other thing is that remdesivir is in short supply. So if we look at patients who are on higher amounts of oxygen and mechanical ventilation and low flow oxygen, ambient air, and split the duration of therapy, 5 versus 10 days, the important thing to notice is that those who received the drug for 5 days are no different than those who received the 10-day course. So this is a very important take-home message when you have a short supply of a drug, that more is not necessarily better. And if we can catch folks right in the earlier phase, then we may be able to mitigate the disease process and have them discharge without progression of the inflammatory response or viral replication. So the thing that really had gotten my attention, and this was back in late January, and this, since publication, this article has been retracted mainly because they interrogated the first index patient who had traveled from China to visit Germany for a meeting. He had attended business meetings and then went back to China and had developed symptoms of a viral URI. And they say, well, he may have already had symptoms at the meeting. And if those symptoms are just a sore throat and runny nose, well, at that time in January, that's flu season. Everybody had some mild symptoms of some sort. And they were saying, well, there's asymptomatic transmission. Well, of importance is that there were patients who weren't even at the meeting who were exposed to people at the meeting, and they all developed symptoms later on. So this to me shows that there was significant transmission, and it was easily transmitted, even asymptomatically, not necessarily from the first patient, but amongst other people and others who weren't even at the meeting. So that led me to be concerned about just spread through airlines, travel, and people who might confuse it with flu. So now we're in this situation where we don't really have a great drug, we don't have a vaccine yet, and we are talking about masks. Our communities are opening up, and I want you to be able to get out safely. I don't want you to feel trapped. And many people are saying, is this mask better than another? They're witnessing people in the community who don't wear masks, who feel that they will be fine. So we do know, compared with not wearing a mask, and this is a great little picture that was just published last week in Science magazine, that if you have an infected asymptomatic person who's talking to you, these respiratory droplets, which I love these slides because those are all these little droplets to give you an idea, can be transmitted to you. And that without a mask, this person can infect another person. And but if a person had a mask on, those viral particles will reach the mask. So if you touch the front of your mask and then touch your nose, you can infect yourself. Now, if the infected asymptomatic person or even symptomatic person had a mask on, they reduce the amount of particles transmitted significantly. They may still reach your mask, but not in the concentration as if that infected person would have transmitted without a mask. There will still be a risk to anybody who isn't wearing a mask. So that's why both people wearing masks are important. They are not perfect, they are not N95, but they will significantly reduce your exposure to the virus. And we still don't know whether is it a few little virus particles that will infect a person, or is it a significant concentration? Likely it's going to be a significant dose and concentration. However, if you're vulnerable, it won't take much for the virus to infect that host. So the best way right now is to minimize exposure to the virus by wearing masks, both um, everybody possible wearing a mask. Initially, we had significant contradictions in our public health messaging because there was a scarcity of N95 masks, and people were rushing to Home Depot and buying out the supplies, and there wasn't enough for hospitals to prepare. They misguided us and said that masks should be worn reserved for healthcare workers exposed to higher concentrations of virus, and that simple face masks don't provide protection. And they didn't want to scare the public. But they did say that it does decrease transmission by the ill person using the mask, and that it was better to social distance, wash hands, avoid crowds. But I think this type of messaging early on February 29th, this was published in the New York Times, was misattributed, and the headlines were not straightforward, and now we've developed a mistrust for wearing masks and public health messaging. So we've got to do better. If we look at this is a cough and a sneeze from my flu presentation that I gave a few months ago. And, at that time, these are respiratory droplets. This has been powdered and the picture was taken immediately just to show you what respiratory droplets can do from a cough or a sneeze. And this on the right is what we in healthcare use to protect ourselves from respiratory droplets if we enter the hospital arena and are exposed to COVID patients and are not in what we call aerosol generating activities or procedures. So if a COVID patient is not actively coughing or in the middle of a treatment that will generate these respiratory droplets, a shield and face mask is sufficient, with distancing and frequent hand washing and gloves and a gown. However, if we are doing some significant procedures on these patients, then we just switch the mask to an N95, still maintain the face shield. Now, I'd like to take this idea from what we're doing in the hospitals and show you a way that a lot of people have asked about testing. That's probably a very common question that I receive. So if you have any fever or any concerns, I can test you at your car. I did this in antibody testing a few weeks ago from a kit from Korea, which they say has a very significant sensitivity and specificity for the SARS-CoV-2 virus, the antibodies, I should say, that we developed for that virus, and where you just take a couple of drops of blood and put it in these little chambers, and you put a reagent in, and then it's kind of like a pregnancy test, and if you have antibodies, you'll see a line form. I was negative as anticipated. The nasal swab that I do is a viral swab done by polymerase chain reaction, or PCR. Unfortunately, there's a 30% false negative rate, so repeat testing is advised if you really think that you have the virus, but a positive test is a positive test. So we still are kind of hanging our hat on the nasal swab. We really don't know what to do with the antibody testing right now. We don't know what it means. There's a 50%, it's a 50-50, false positive and false negative. And what does that mean? Are you going to have immunity? Are you going to be protected? We really don't know. When will there be a vaccine is a big question. Over 100 trials are in progress right now, and a vaccine is going to be like the space race. The first country to develop a vaccine will gain a political and socioeconomic advantage. The WHO is trying to put together a collaborative effort in sharing of the vaccine and creating a global allocation protocol. We still have concerns. Is there going to be lasting immunity? Would a vaccine prime a person to then develop a higher cytokine storm? We don't know. Is it going to be partially effective like the flu shot, where you still can get flu-like symptoms, but it mitigates your risk for death? So more to follow. The studies are still ongoing, and we're very hopeful that there will be something. I would anticipate a vaccine available sometime in January for the general public. I think if there is some early release, it might be in October. And I would anticipate priorities that healthcare workers who are most impacted in direct patient care with COVID-19 would be the ones who would be prioritized, as well as susceptible individuals. The age cutoff will be maybe perhaps 55 instead of what we usually use as 65. People with diabetes, high blood pressure, immune compromised are likely to be prioritized. It was interesting last week, as of a poll was done saying if there was a vaccine available right now, would you take it? And only 40% of Americans said they'd accept the vaccine, which is about similar to our current flu shot rate. At this time, we had some questions during the live Zoom presentation. There were questions regarding safety of going out. What was my thoughts regarding other countries and how could we learn from them? I think if we looked at Taiwan and South Korea and Singapore, we would say that they have I guess more population-based management led by public health, and those folks are used to wearing masks due to the prior experience with SARS and MERS, and implement those measures quite quickly. There's a lot of public health messaging that they are already geared up for, and they're very highly effective. Our population and our democracy, and currently with the protests, our behavior is a little different. And right now, wearing a mask is considered maybe a little oppressive to some. So our population dynamics is going to determine our public health response. And we can't compare ourselves to other countries whose populations behave differently. So unfortunately, we can try to take some lessons learned from those countries. They've experienced these diseases earlier, try to implement some of those measures, but eventually it will be up to our population and wearing masks and respecting each other with that and getting vaccinated. I'm hopeful for an antiviral as well. So let's switch gears and talk about the personal care kit that you have. I'm really excited that I've been able to give this to all of you. And in the bottom of it, I know this was supposed to be originally our travel kit, and I hope someday it will be. But in the bottom of it is this emergency blanket and poncho. I'd like you to remove that and put it in the glove compartment of your car, and that way we have some room in the bottom part for some of these items to your right, which is a actively working flashlight, lots of safety pins, some scissors, tweezers. It wouldn't help with the splinter unless it was large, and even a whistle for emergencies. In the middle section, I've got some wound care items and skin care items. There's a cold pack. There's also bandages, band-aids, adhesive wound dressing, gauze, cotton balls. There's povidone wipes, which help to kind of keep things sterile. Sting relief pads, alcohol swabs, wound cleanser swabs. I've also purchased some hydrocortisone cream, first aid burn cream, bacitracin. I prefer that over Neosporin for you. And I've also purchased an insect repellent because when you're traveling, or even sometimes even in Southern California, mosquitoes are prevalent, and the best defense is not getting bitten, especially since we don't have vaccines for many mosquito-borne diseases such as West Nile virus or dengue. So insect repellent is very important, especially when you travel. This one swab can actually last you about 7 days. You put it on after the shower, just to exposed surfaces, and don't forget behind the ears and the neck. And then put it right back in and fold up your packet. It is by Avon Skin So Soft. It is very effective, and it's not as thick and gooey as DEET. In the medication section, I purchased all of this for all of you for the what if scenarios. If you got hurt yourself, had cold, flu, nausea, vomiting, diarrhea, headache, constipation, things that can happen when you're out of the home traveling, or even at midnight and all the drugstores are closed. So here's a packet of Marilax for constipation, Pepto-Bismol. The interesting thing about Pepto-Bismol is that it can also help prevent travelers' diarrhea. Emergency for flu or any kind of bacterial infection, just to help boost up your immune system. Here's a little product called Dream Water that I discovered that my daughter actually swears by, and it's all natural, and it has melatonin in it, and it helps prevent jet lag and ease you into a gentle sleep. There's oral rehydration solutions, some natural saline tears, a lozenge, aspirin, Aleve, ibuprofen, diphenhydramine for any allergic reactions or a bee sting, Tylenol, some Tums like antacid, and like a cold relief medicine like Dayquil and NyQuil. And I've just thrown those in there for you to get through the night until you can call us. So that leads us to some self-care during COVID-19. So a lot of people are advocates of vitamin C. I am as well. 1,500 milligrams a day is supposed to be healthy for you. Vitamin D, maintain adequate levels. We don't want to overconsume vitamin D since it is a fat-soluble vitamin and can lead to toxicity. And our next lecture will be on vitamin D. Zinc lozenges are also antiviral. Definitely wash your hands. Get an adequate sleep, 8 to 9 hours. One thing I'm finding is that folks are eating less junk food, and they're caring about nutrition because they want to be strong in case exposed to the virus. Exercise is always healthy. It's important to get a good night's sleep, and if we aren't exercising, our bodies aren't fatigued enough. I think over time, we'll learn to develop a new greeting like namaste, bowing. I think these ancient cultures probably implemented these forms of greeting due to previous infectious disease outbreaks and pandemics historically. And I think that maybe we can do like a virtual hug gesture. Mindfulness, meditation, yoga are also things that will help you get through this. I know this is a stressful time, and some of that stress has been promulgated by media, which cycles repetitive stories and doesn't have as much good that's happening out there. And I think try to limit negative conversations or overwatching the news. I know it's hard to do, but I do think that that would be useful. And this is a list that we put together through the American Thoracic Society's Integrative Therapies Work Group. So with that, I'd like to conclude the presentation and thank you very, very much for your time and attention.